good afternoon, everybody. Welcome to my presentation about my progress in the last 3 months about my PhD topic, the Diagnostics of Pancreatic Neoplasms. My name is Zoltán Bánfalvi. I'm an internal medicine resident and a first-year PhD student in the Institute of Pancreatic Diseases. My vision is that patients with suspected pancreatic neoplasia should be diagnosed as early and efficiently as possible. Therefore, our mission is to identify the most reliable and accurate diagnostic methods for it. Currently, I have 2 ongoing projects. The first one is about different endoscopic ultrasound-guided techniques in the diagnostics of pancreatic cancer. We approach this problem by the methodology of a systematic review and meta-analysis. The second project is about different anticoagulant methods for acute pancreatitis-related Splanchnic venous thrombosis, and we are designing a study protocol for it, for a randomized trial. The working title of my first project is comparing the diagnostic accuracy of EUS-FNB to on-site evaluations in the diagnostics of pancreatic neoplasias. Pancreatic cancer has a third highest mortality with more than 60,000 cases per year in the USA, and the time is the most important factor regarding to it. A previously resectable cancer can easily progress into an irresectable state, so we should be very fast with the diagnosis. The main diagnostic method for pancreatic cancer is endoscopic ultrasound-guided fine needle biopsy, which has a great diagnostic accuracy, sensitivity, and specificity on its own, but there are one problem with it: the success rate of the tissue acquisition. There are 2 supplementary techniques for it. The first one is ROSE, that's a rapid on-site evaluation, which is done by an experienced cytopathologist with expensive equipment in the endoscopist room. The other one is MOSE, that's macroscopic on-site evaluation, which is done by the endosonographist by his own eye, by examining the tissue sample which he took out from the cancer. Our aim is to identify the methods to acquire the adequate histopathological sample as soon as possible. Our clinical question is that do MOSE and/or ROSE improve the success rate of tissue acquisition compared to standalone EUS-FNB? We will examine the population of patients with suspected pancreatic neoplasia. We will compare the diagnostic accuracy for pancreatic cancer in these different interventions, ROSE, MOSE, and combined. The reference test will be the definitive histopathological results. Our hypothesis is that MOSE and/or ROSE can improve the success rate of tissue acquisition, therefore allowing for a better diagnostic accuracy compared to standalone EUS-FNB. The clinical implication would be that if the correct diagnosis can be made earlier, the proper treatment can be started faster. We conducted a systematic search on 12th of October with the following search key: the domain 1 regarding to the pancreatic cancer patients, the domain 2 for the different endoscopic techniques. We conducted the search in 5 different databases, and there are few meta-analyses from this topic, but only separately for ROSE or MOSE, nothing combined. There are no Prospero registration currently in. After duplicate removal, we had around 2,600 articles, and we conducted the title abstract selection, and we are left with 232 articles. Our topic is feasible. The Prospero registration was accepted. We completed the title abstract selection, and currently we are in the full text selection phase, which we hopefully finished in this month. The working title of my second project is investigating the effectiveness of direct oral anticoagulant and low molecular weight heparin therapies in the treatment of Splanchnic venous thrombosis in acute pancreatitis patients after the hospital discharge. It's a long title. So acute pancreatitis has an incidence of 34 cases per 100,000 people, with a mortality rate up to 30% in severe cases. There are several local complications to it. One of them is Splanchnic venous thrombosis, which has an incidence around 20% in all of acute pancreatitis cases. There are lots of clinically relevant things regarding to it, like portal or segmental portal hypertension, which can lead to very cell bleeding. The main diagnostic methods for it is color Doppler ultrasound, contrast-enhanced CT scans, and in selected cases, endoscopic ultrasound. The current ISTH guideline recommends early anticoagulant therapy, but for the DOAC treatments, they are mostly off-label in the most countries in Europe. So our aim with this study is to determine the most effective method of anticoagulant therapy in these patients. Our clinical question is that the use of DOACs as effective as LWMH in the treating the pancreatitis-related splanchnic venous thrombosis after hospital discharge. The patient's population will be acute pancreatitis patients with splanchnic VT at the hospital discharge. We will compare direct oral anticoagulants with LWMH therapy, and our primary outcome would be the recanalization rate at the 3rd month. Our hypothesis is that DOACs are non-inferior to LWMH therapy in the treatment of pancreatitis-related SVTs. And one of the clinical implications would be that if we have a non-inferior PEROS alternative treatment, the patient compliance would be increasing, and it's allowing for a quicker recovery for them. So our primary outcome will be the recanalization rate of the vessels in persons at the 3rd month CT scan. And there are a few secondary outcomes. For us, one of them is the recanalization time, which we try to measure with Doppler ultrasounds in the 1st and the 2nd months after discharge. We will look into the rethrombosis or bleeding side effects, the quality of life, and mortality and portal hypertension severity. So for the interventions, we will plan to make 2 groups for the patients. Group 1 will be the patients with portal vein thrombosis and or subtotal superior mesenteric vein thrombosis. Subtotal because a total superior mesenteric thrombosis is a surgical case, is acute abdominal case, it needs immediate intervention. The second group would be the patients with splenic venous thrombosis in progression, and in progression because stable splenic thrombosis patients don't need any anticoagulant treatment, they only need observation. We will randomize these groups into 2 therapeutic arms. The first intervention arm would be the direct oral anticoagulant treatment, for example, Apixaban. The second arm would be the comparison low molecular weight heparin treatment, for example, enoxaparin or Clexane. For a quick summary in the end, the first projects would be different endoscopic diagnostic and on-site evaluation techniques in pancreatic cancer cases, and we plan to submit this paper in September 2025. The second project would be a study protocol for a randomized non-inferiority trial with different anticoagulant treatments in acute pancreatitis-related splanchnic venous thrombosis, and we plan to submit it in June 2026. I would like to end my presentation with a quote from Neil deGrasse Tyson, that the good thing about science is that it is true whether or not you believe in it. Thank you for your attention.
Congratulations on your presentation. I would like to ask, in your opinion, which on-site evaluation technique is better?
I think there are no good answer for that because each of them has its own pros and cons. MOSE is good because it's only need the endosonographists who needs experience for it but don't need very expensive or special equipment for it. ROSE is good because it's done by an experienced histopathologist, cytopathologist, but it needs a really expensive and hard to obtain equipment which are not available in most parts of the world. We have it in our institute, we use it regularly, but a lot of centers don't have it, so it depends on the situation.
Thank you.
Thank you for your great presentation. I have one question. What was the main reason behind the development of onset evaluation techniques?
Thank you for the question. So, the main problem with EUS-FNB is not its sensitivity or specificity, but sometimes if we take a sample and we don't take a look at it immediately and send it to the pathologist, it came back as it's non-diagnostic. Don't have enough cells in it, it's just blood coagulum and so on. So they developed these techniques for it to examine the specimen immediately after the biopsy, so we can make sure we're sending a correct sample to the pathology and don't need to organize another endoscopic session which take days or even weeks in some places.
I have one question for your second project. That which of the imaging modalities do you consider the best for the follow-up of the thrombosis?
the imaging of the splanchnic venous thrombosis it's not so easy because there are different veins, different people, different body structures, obese people and not obese people. So every technique is good not good for everyone. For example, the ultrasound, the Doppler ultrasound is good for a portal vein, but not so good for the mesenteric vein because the bowel gases and the obesity. And it's good for the splenic vein if the ultrasonographist is experienced. The CT scan is good for all because contrast can go to every vessel and you can have a clear picture of the status of the vessels. So it's good. Endoscopic ultrasound, which I mentioned, is only in selected cases where the patient is too obese or has contrast allergy and so on. Yes, so it needs to be combined. But the CT scan is the gold standard today.
Do you have a feeling? Do you have a number? Do you know what is the proportion, what is the prevalence of splanchnic vein thrombosis in AP patients who are on prophylactic low molecular weight heparin? Because historic data doesn't tell us that the high proportion we see is on or off prophylactic dose claxane.
There was no clear data about this in the literature I was going through, but we can only just suppose that each hospital, even our hospital, use prophylactic anticoagulant for their patients to prevent the thrombotic events, but there was not clearly stated in the data. Like in the background slide, I said that it's around 20%, but the article that reported that it's not stated.
So I would suggest that we look at our own data in which we have consequently used for every patient the claxane and see what's the prevalence. It may be much lower, and then that may influence how you plan your study, your RCT, the RPAD.
That's a good idea. Thank you.